Good afternoon. My name is Lindsay Keller, and I'm an adult gerontology nurse practitioner student here at Clemson University. And today I would like to present a case to you. Mr. Jones is a 64-year-old Caucasian male. He came into the office today complaining of numbness, burning, and tingling on both of his feet bilaterally. Mr. Jones cannot remember when mild symptoms began, but he guesses about 1 year ago. He also states that about 2 months ago the symptoms became worse, and therefore he made an appointment and came in today. The three systems that we will review are Mr. Jones's dermatological system, his neurological system, and his musculoskeletal system. Mr. Jones denies any syncope, seizures, paralysis, or paresthesis. He only complains of the burning, tingling, and numbness of both of his feet bilaterally. Mr. Jones has no obvious rashes, trauma, or any skin breakdown. The patient does have calluses on both feet, near his great toes and on his heels. Mr. Jones denies any joint pain, swelling, stiffness, cramping, malaise, or weakness. His past medical history includes hypertension, diabetes with a recent hemoglobin A1C of 5.8, dyslipidemia with stable cholesterol labs, CAD, in which he is followed by cardiology, and he has previously had low back pain due to degenerative joint disease of the lumbar spine. He has only had trouble occasionally, and the last time he has had trouble was 2 years ago. And of course, he came in today for his recent complaint of burning, tingling, and numbness on both of his feet. Mr. Jones has a negative social history and does not smoke. He only drinks socially with friends and approximately 4 alcoholic beverages throughout a whole weekend and none throughout the week. He is sexually active with one partner, his wife, of 27 years. Upon physical exam today, his vital signs were stable. His blood pressure was 117/79. His temperature was 97.4. His respiratory rate was 14, and his heart rate was 74. And Mr. Jones also denies any type of pain. His skin is well hydrated with normal upon inspection. He has no rashes or petechiae, no bruises. He has normal color and texture, and his capillary refill is normal under 2 seconds. He does have bilateral calluses on both feet near his great toes and heels. Neurologically, Mr. Jones is alert and oriented to person, place, time, and situation. He has normal muscle strength, deep tendon reflexes, normal coordination, normal gait and station. Patient does not have normal sensation on feet bilaterally. Patient has a hard time differentiating between dull and sharp on the 2-point discrimination test on both of his feet. Upon physical exam of his musculoskeletal system, he has no clubbing, cyanosis, no deformity, no trauma, no pedal edema. His peripheral pulses are intact with normal joints. The patient has complete range of motion and is negative for pain. I also did a quick back exam to rule out any pain or tingling or numbness radiating from his lower back issues previously that would radiate down to his feet and be portrayed as numbness, tingling, or burning. He had normal curvature and mobility of his back. He has no pain or tenderness. He also has no complaints of any type of back pain whatsoever. Mr. Jones also has no known drug allergies. The 3 differential diagnoses that we determined were 1, diabetic neuropathy, 2, neuropathy related to degenerative disc disease of the lumbar spine, and 3, Raynaud's disease. His labs and tests that were significant for this was 1, his hemoglobin A1C. His was actually stable at 5.8. Now this was a good learning opportunity for me because I realized that 60% of all diabetics will eventually develop a diagnosis of diabetic neuropathy. This is not necessarily dependent upon how controlled or poorly controlled a patient is. For example, for him, his hemoglobin A1C was 5.8 and is very stable. Continuing on, I also performed the 2-point discrimination test using a sharp and a dull object on his feet. I had the patient close his eyes and tell me which was which he was unable to do the majority of the time. Also, because Mr. Jones has a history of the low back pain with degenerative disc disease of the lumbar spine, I performed a back exam and also included a straight leg raise test in which it was negative. Furthermore, I also tested complete range of motion of his bilateral lower extremities. His range of motion was intact, and also a visual exam of his skin was performed in which there were no abnormalities other than the calluses. And lastly, to rule out any type of Raynaud's disease, I questioned whether he has ever had the same feeling of tingling, numbness, or burning in his fingers, or if his fingers or toes have ever turned a blue tint upon the weather being cold or holding a cold drink, anything like that. The patient denies all of that. Upon diagnostic and treatment plan, because the patient failed the 2-point discrimination test and proved that his sensation was inadequate, in conjunction with a negative dermatological assessment and a negative musculoskeletal assessment, I concluded that the patient has diabetic neuropathy. The patient was started on 300 milligrams of gabapentin or Neurontin that he can take at night just in case it makes him a little sleepy. He was also taught the importance to check his feet daily and to monitor any type of blisters or anything that could get stuck in his foot that he may not be aware of. We explained that this could lead to diabetic foot ulcers or even amputation and major infections. The patient verbalized understanding, and we agreed on a follow-up appointment within 3 months, and that he is to call if he does not have diminished symptoms in the next 2 weeks. Thank you so much for listening.